इसको ऐसे रख देना फटाफट, जल्दी लो।
Okay.
जल्दी लो ना, रख दो।
Okay, then before going to the topic, what is refraction? That we should keep in mind. Okay, then refraction, the word meaning, it is that we had already studied in our +2 at the pre-degree level. That is refraction, it's a deviation of light, not the reflection or rebounding, but it's a deviation, it's a bending of light when it passes from one medium to another. Then in according to our Ayurvedic concept, we can correlate the track of, otherwise the bending of the light rays with Vata and Kapha. In Vata, the focusing light rays, and Kapha, that the medium through which the refraction happens. Then the refraction of light by Vata and Kapha, along with photochemical changes that take part in the retina, that's induced by Pitta, that makes vision possible. Then coming to the refractive errors, then that is Pradosha balance is disturbed in refractive errors. According to Ayurvedic concept, we are treating it with the dosha predominance. Then the light ray here, the light rays don't focus on the retina. Normally, we know the light rays from an object that we see is clearly focused in the retina, but here it may focus beyond the retina, or in, before retina, or maybe more than one point in retina. Then the most common refractive errors are the myopia, hypermetropia, astigmatism, and most commonly presbyopia is also considered as refractive errors, but actually it is not an refractive error. It is an age-related change in the eye. Then it is considered the second leading cause of blindness in India. Okay, before going to the refractive errors, we should keep in mind the basic anatomy that we all know, that the eyeball, then the orbit. Orbit, that means the pyramidal bony cavity in the skull in which the eyeball is located. Then coming to the accessory structures. See the outer layer that we know, outer layer, otherwise called as the fibrous layer, that gives the structure to the eyeball. That is the sclera, and anterior part of the sclera is cornea. Sclera and cornea both are the part of fibrous part, but anteriorly the sclera become very transparent, and it is known as the cornea. Cornea is the most smoothest and transparent part in our body. Then coming to the middle layer, that is here.
Hello, sir. We can hear you, sir,
hello?
But it is a bit blurred. Sir, hello. It is a bit blurred. The audio. Hello, sir. Can you hear me?
Okay. Yes. I can hear.
Can you just okay. Can you please put the mic a bit away from the mouth so that it will be a bit more clearer, I think.
Okay. Now it is clear.
Okay. Now it is clear, sir. You can continue.
Okay. Then okay. The mic was little bit near to my body. Okay. Then this is that cornea that we can see. It is not smoothest and anteriormost part of the sclera, that is cornea. This picture is, we can see through the slit lamp. This slit lamp examination view. Then next coming the middle layer, that is the iris, choroid, and ciliary body. These three layers are called as the vascular layer. That means the blood supply is predominant in this area. I got the nourishment from this layer, that is the middle layer, that is iris, choroid, and ciliary body. The innermost layer is the retina, that is the nervous layer. The lens is also the inner part, therefore it is considered as inner layer, but it's not a layer, but is seen in the inner part. Then keep in mind the structure of eyeball, where the lens is situated, where the cornea anterior part, then the iris, then we can say the anterior chamber. Anterior chamber is filled with aqueous humor, it is very watery, and the posterior chamber, it is filled with vitreous humor. It is not watery, but it's jelly-like. Then coming the optic nerve. Then just keep in mind the anatomical positions. Then that's coming the lens. The lens is a transparent structure in the inner part of the eye, which lies directly behind the eye, behind the cornea and iris. The lens change in shape to allow the eye to focus on objects. The lens focus light rays on the retina. Then these are the changes that happens in the lens while we seeing the distant objects and the near objects. See that while we seeing the near object, the lens is in a shape that is in a rounded shape. That will become more powerful because the light rays is coming from very close. Very close. That means it is a divergent lens. So we have already the light rays coming from near object is not in a parallel. It is in a divergent condition. So the lens have to work more to make it convergent to focus in the retina. While we seeing the distant object, the lens is in an elongated shape. Here, the power of lens is minimum because the light rays is coming from an infinity, or while looking on the distant objects, the light rays are parallel, almost parallel. Therefore, the lens having should be in a elongated. That means its power should be decreased. Otherwise, the lens is in an elongated state. Then coming to the ciliary muscles, we should keep in mind the working of ciliary muscles while dealing with the refractive errors, because the ciliary muscles are the circular muscle. We can see the red colored muscle. It's in a circular shape, which is seen around the suspensory ligaments. From the ciliary muscles, the suspensory ligaments start and it is attached to the periphery of the lens. One thing we should keep in mind is that while the ciliary muscles are constricted, what happens? When the ciliary muscles when constricted, the round shape becomes small in shape. That it is constricting, it becomes small in shape. That time the suspensory ligaments become very loose and the lens become round in shape. When the suspensory ligaments are relaxed, what happens? The diameter of that some ciliary muscles increases and the suspensory ligaments gets tightened, and it will pull the lens at its periphery and it become elongated. Then these are the accommodations. We can see the eye accommodates for close vision by tightening the ciliary muscles. Tightening the ciliary muscles means that it will constrict and the center becomes small. That time what happens, the suspensory ligament become very loose, which is attached inside the ciliary muscles. That time the lens become more rounded in shape. That is when we look in near object. This error is what is happening in presbyopia. You may have noticed in presbyopia the patient first symptom is hypermetropia. Otherwise, they can't see a near object because the lens cannot. The lens loses its elasticity, so that it can't come to the shape of a round. Or otherwise, it is very, very difficult to make it stretched. Both stretching and coming to the round shape, both are affected in presbyopia. Therefore, it is considered as not an refractive error, but it's an age-related because of the loss of elasticity of the lens. Then this is the orbit where which eye is located. You can see the position of the eyeball. The four extraocular muscles, they are the superior rectus, then inferior rectus, lateral rectus and medial rectus, and two oblique muscles. You can see the oblique muscles. This is the superior oblique muscle and the inferior oblique muscle. Superior oblique muscles start from the posterior part of the equator of eyeball and it come medially and forward to the eye orbit, and it goes through a pulley-like organ, pulley-like bony structure. It is called a trochlea and is inserted back of the eye, that is to the apex of the orbit. So all the four rectae groups and the oblique groups are inserted to the sonule of sin. Otherwise, it's a ligament. It is in circular shape in the apex of the orbit. Then coming the accessory structure, just keep in mind the position of lacrimal gland is laterally and superiorly, then the caruncle, then eyelids. Just see the position of the accessory structures. Then coming to the refractive errors. Mostly refractive errors, the main word is emmetropia. Emmetropia means normally. Emmetropia that light can be defined as a state of refraction when the parallel rays of light coming from infinity are focused into the sensitive layer of retina with the accommodation being at rest. That means normally the light rays coming from outside, whether it is from the distant object or from the near object, both are focused into the sensitive layer or the nervous layer, that is a retina. Then ammetropia means not normal. A condition of factor is different state of refraction when the parallel rays of light rays coming from infinity are focused either in front or behind the sensitive layer of retina. Ammetropia includes the myopia, then hypermetropia, astigmatism, etc. And types of refractive errors. The first one we all know, that is myopia and hypermetropia, astigmatism. Myopia, that means short-sightedness. The word itself is small word, myopia. Hypermetropia is a long word. Therefore, we should not complicate it with the name itself. Myopia, small word, that means short-sightedness. It's a type of refractive error in which parallel light of light coming from infinity are focused in front of retina. In myopia, what happens? The image is formed or otherwise focused in front of retina when accommodation is at rest. See what is happening in myopia. The patient will see like that. They will complain while driving itself. They can see the kilometer reading, then the petrol gauge, etc. But they can't see the distant objects like road, etc. Also, students or otherwise children will say they can't see the. Yes.
Hello, sir. Sir, can you please switch off? Hello, can you please switch off your video also, sir? So we may get a better audio quality, because we are recording this, no? Recording the audio. So we need very sharp voice. So can you please switch off your video? Just the screen is enough. So it can be, so the net utility will be less.
Okay, 1 second.
Okay, sir.
Can you hear me?
You can continue, sir. Yes, sir. We can hear. Yes, it's better now. Okay.
Then this is what is happening in myopia. I've already told nearsightedness. The lens that is present in our eyeball is convex. That should be keep in mind. That is convex lens. By convex lens, here what happened? The light rays from far is focused in front of retina. Light rays focus in front of retina instead of falling on retina. Yes, this is the same condition. The first image is normally images are formed directly on the retina, creating good vision at a distance. Then the second image is like myopic eye. Images are formed in front of retina, causing blurry vision at a distance. This can be corrected with the spectacles and contact lenses. Up to full correction can be given. The third picture is in high myopia. This picture is shown because we should notice the type of myopia. Here what happens, you should notice the length of eyeball and the size of eyeball. Here the axial length of eyeball is increased. That is why the image is formed in front of retina, because the retina is not in the correct position. Retina had gone backwards because of the enlargement of eyeball. The third picture is very high myopia. Then the view of the myopic patient. Then coming to the etiologies of myopia, so many etiologies are there. The most common is the axial myopia. That means result we had already told result from the increase in the anterior posterior length of eyeball. Here what happens when the anterior posterior length is increased, the retina is pulled backwards, or it is changed to another position backward. Therefore, the focal point become in the front of retina. The next one is the curvatural myopia. This occurs due to the increased curvature of cornea, lens, or both. Here, what happens when light rays coming from the cornea, lens are converged into the retina. When the convergent power or the convergence or the curvature increases, more the curvature and the image is formed in front. When the curvature is somewhat slightly less, that image will go to the retina. Then coming the index myopia, that is result from the increase in the refractive index of the crystalline lens associated with the nuclear sclerosis. That depends on the content of change in the content of the cornea or the crystalline lens, and the light rays are more curved or more refracted. That causes myopia. These are the main three kinds of myopia we should keep in mind. That is congenital myopia, and simple myopia that we are seeing in the daily OP, then degenerative myopia. Congenital myopia, simple myopia, and degenerative myopia. Congenital myopia, as its name denotes itself, since birth, starts since birth. Usually the error is about -8 to -10 diopter. Mostly remains constant. May be associated with other ocular congenital anomalies. Then coming to the nidana, in congenital myopia, nidana is bija and janani apachara. Bijam, bijabaha avayava dushti and jananya apachara. Then sahaja vyadhi, sahaja vyadhi, hence it is asadhya. Then next common type of myopia that we are seeing in the daily OP are the simple myopia. It's common severity, it's biological variation in the development of eye. Then it all starts at school age and progress till adult age. Usually the error does not exceed -6 to -8. Then this is simple myopia. In this case, the patient will come with a complaint of that the child is very poor in learning, or he is making some errors in the class daily notes, and he is in poor listening. Then we should test the eye, whether he or she is having myopia or any other refractive errors. Then the third type, that is a degenerative myopia. Here it is rapidly progressing error. In case this is high myopia or more than -8 diopter is seen in this degenerative myopia, and mostly it is seen in early adult life, that is about 20 to 30. From this age it will start, and also usually associated with the degenerative changes of retina. Genetic factors also play a major role, so we should take the history of the patient very clearly in the refractive case taking. Then coming the hypermetropia. Hypermetropia, the word is a big word that denotes long sightedness. So, an refractive state of eye where the parallel rays of light coming from infinity are focused behind the retina. Thus, the posterior focal point is behind the retina, which therefore receives a blurred image. This is what is happening in hypermetropia. The patient will tell us about their good in vision for the distant vision, but they are poor in near vision. Also, they will tell the difficulty in the reading, but they are very good in reading distant objects. This is what happening in hypermetropia. That's the image. See the yellow beam of light that is focused beyond the retina. Image is focused behind the retina. Therefore, the patient feels a blurred image. Then the etiology, coming to the etiology, is same as that of myopia. Here what happens, axial hypermetropia. Here the shortening of axial length of eyeball occurs. In myopia, it is what happening is the axial length of eyeball is increased, but in this case the length of eyeball is shortened. Also, curvature hypermetropia occurs due to the comparatively less flatter curvature of cornea or lens. The more the curvature, the light rays will refract more and will be focused anteriorly. But here the curvature is lost, or otherwise curvature is comparatively less. So the light rays are focused beyond the retina. Then coming to the index hypermetropia, result due to change in the refractive index of lens. That means the molecular level, or otherwise nuclear constancy of the retina lens is altered. Then another condition is absence of lens, otherwise called aphakia. This is either congenital or acquired following the surgical removal of the lens. Normally our eye is having a lens which is convex in shape. Convex, that means convergent lens. It will converge the light rays to the retina. But if that lens is absent, what happens? The parallel light will go directly to the retina. There will be no focal point. Here also there will be blurred images. The patient vision will be hand movement, or otherwise 6/60 like that. They can't even see or read clearly. Then coming to the clinical features, the patient having refractive errors, mostly in hypermetropia, there will be tiredness of eye, also temporal or frontotemporal headache, and severe watering, which is due to the straining of the eyeball. The reflex for watering will be initiated, and severe watering will be there, and mild photophobia will also be there. Then coming is astigmatism. In myopia and hypermetropia, in both cases, there is only one focal point. But that one focal point that is falling behind the retina in hypermetropia and in front of retina in myopia. But in case of astigmatism, what is happening here, more than one focal point is there. It may be behind the retina or in front of retina. That means myopia means that means the image is falling in front. Hypermetropia means the image is falling behind. But in both cases, only one focal point is there. In astigmatism, it's a typical refractive error where the refraction varies in different meridia of eye. Consequently, the rays of light entering in the eye cannot convert to a point focus, but form focal lines. More than one focal point is there. This is happening in myopia. You can see that the focus point is more than one in the second image. Then astigmatism causes severe strain to the eyeball, also combined with nearsightedness or long-sightedness. The images may be falling in front or behind the retina. That is nearsightedness or long-sightedness. That is, it may be associated with myopia or hypermetropia. Then we call it as myopic astigmatism or hypermetropic astigmatism. Then coming to its etiology, usually occurs due to the unequal curvature of cornea. Normally our cornea is very smooth and it's very clear and very smooth and equal curvature is there. But in some cases, like when the surface of the cornea is irregular, when its smoothness is lost, what happens? The light rays will not focus to one point. Instead, more than one focal point occurs. Rarely, it may occur due to subluxation or abnormalities of curvature of the lens. Lens itself, lens is the main converging organ. Cornea is also there. Any abnormality in the lens, also astigmatism may occur. Astigmatism is regular astigmatism and irregular astigmatism, two types. Then coming to the presbyopia. Presbyopia is actually not considered as a refractive error. As I earlier told, it is considered as an age-related condition. That's a common type of vision order disorder that occurs as you age. It is often referred to as the aging eye condition. The inability to focus up close. The problem is associated with the refraction in the eye. Then, presbyopia is not an error condition of physiological insufficiency of accommodation leading to failing vision for near. Actually, what happens in presbyopia is the elasticity of the lens and a suspensory ligaments is lost in presbyopia. Its first symptom is the hypermetropia. That means the patient can see the distant objects clearly, but he or she can't see near objects, especially reading, writing, etc. The main factor is that it will start usually in 40 years of age, but nowadays it is seen to be starting at 37 years. Then what is happening in presbyopia? Here itself, the light rays is in the first stage of presbyopia. Hypermetropia is the hypermetropia is happening. What happens? The image is falling behind the retina. Or in severe case of presbyopia, myopia, or otherwise, the elasticity of the lens is low. Therefore, the patient can't see the distant objects and also the near objects. In that case, we are correcting the lens with bifocal. Two powers can be seen in that type of spectacles. The one power is for the distant vision and the second power is for near vision. Then coming to the etiology, decrease in the accumulative power of crystalline lens with increasing age leading to presbyopia. There is a decrease in the elasticity and plasticity of the crystalline lens. Age-related decrease in power of ciliary muscles. Ciliary muscles play a very good role in the accommodation. As age proceeds, there may be a decrease in the power of ciliary muscle also. Then the clinical features. Typically, patient complains of slowly progressive difficulty in focusing the near object, while distant vision is not affected. Here what happened, the patient can't see the near vision or can't see the near object, but they can focus it by taking some time because the elasticity is lost. That means the lens cannot move fast because its elasticity is not. But for some more time, it will move to a ball-like structure and a structured structure. See what is happening in the first stage of presbyopia. Nowadays, it is starting at 37 itself. If a patient is having this type of visual impairment, that means they are putting or taking the paper or writings a little bit away from the eye, then we should consider them for refractive tests. Then before going to the what is happening in the eyeball, we should keep in mind the basics of the optics. What is happening when the refraction, the word itself means the bending of light when it passes from one medium to another. See, we had seen in our school classes that light rays coming, passing through a prism. It is bending and is focused to another point. Not focused, but it's bending focus. The incident ray and the angulated ray, we can see what happens in prism. The same is happening in the lenses. See, when a prism is kept in this position, the refraction occurs like that. When a prism is kept in this position, the refraction occurs like that. This is happening in convex lens and concave lenses. Two prisms placed base to base can bring two rays of light originally parallel to a focus. Then two prism placed apex to apex refracted light in, apex to apex refract light in a diverging manner. Yes, happening in convex lenses. Convex lenses, otherwise called convergent lenses. See the tip of that convex lenses, it seems to be a prism. This is what is a convex lenses. When we take in hand, the center part of the lens is very thick and the peripheral part is uniformly thin. That is convex lenses. Then coming, these are also convex lenses. Then how we differentiate a convex lens and a convex concave lenses, or otherwise concave or convex or plus or minus spectacles, that we can be differentiated by moving it. When a convex lens is moved towards right and left, we can say it will move with the movement of that image will move with the movement of lenses. That when we see an object through an lens and we move that lens to one side, if it is a concave lens, that seeing that the image will also come to the same direction of the movement of our lens. But if we are seeing through another convex lens, just move it to right and left, we can see that when we move that lens to right side, we can see the object is moving to the left side. This can be differentiated in this type. In this type, we can differentiate a minus lens and a plus lens. By seeing the lens, spectacle itself, we can even calculate the age of the patient itself. Then next. Okay, then coming to the management of refractive errors. Then in case of myopia, we have already told inside our eye there is a biconvex lens. In myopia, what happens? The power of the lens is increased. Therefore, the more refraction occurs and the light from the distant objects is bent more, or otherwise it is converged more. Therefore, it will meet a point near to the lens. Instead of falling the behind structure, that is the retina, instead it is falling near to the lens itself, because the power of the lens is increased. In that case, we have to take that focal point from that position to far beyond. Therefore, we have to do, in this case, the power of lens is increased. Therefore, we have to decrease the power of lens. So what we have to do is, we have to place an opposite lens with its lens. Then the power of the lens will be decreased. In our eye, it is biconvex lens. Therefore, we want to decrease the power. Therefore, we are placing a negative lens or concave lens in front of eye, so that the combined power will be decreased, or the power of lens will be decreased. Then the corneal refractive power is always constant. Then we can normally the lens refractive power is modified with the accommodation. The axial length of eye is constant except under certain conditions. These are some of the surgical management they are doing in radial keratotomy, then photorefractive keratotomy, then laser assisted in situ, otherwise called a LASIK management. In radial keratotomy, what is happening? They are making some incisions so that the dome of the cornea is become flattened, or it will more flat, so that curvature will be decreased, so that the more bending will be lessened and the image will fall beyond, not beyond, it will fall correctly on the retina. And also another photorefractive keratotomy. Here what happens? The the thickness of cornea is reduced. What happens here? The thickness of due to the present thickness of cornea, the light rays falling from the retina is converged very close to the lens or in front of the retina. So we have to decrease the power of the cornea or lens. Here we are doing we are decreasing the power of the cornea by scraping. Otherwise, we are decreasing by scraping the thickness of cornea. Here these are the procedures. What happens? They are scraping with an instrument. Then another contact lens is placed over this. Then the eye is bandaged for 2, 3, 4 days. After 1 week, we can take the bandage. Also, we should clearly check for any pain or any irritation, because actually there is a wound is there. There is chance for wound scarring. Therefore, we should keep some precautions for in these cases. Then this is another type of refractive management. They are creating a flap that they are opening the first layer of cornea, that is a pigment, not pigmented, the epithelium of the cornea is opened, and then the stroma is scraped with a laser beam. Then the flap is closed. Then in the hypermetropia, the management is convex lenses. What happens in our eye? There is a convex lens. Here the light rays are focused beyond the retina. Here what happens? The power of the lens is not adequate. So we have to increase the power. Inside eye there is a convex. Therefore we have to increase. What we have to do? We have to take the same lens, that is convex itself, in front of eye. So the total power will be increased. So that the image power will be increased, the more will be the bending, so that instead of going behind the retina, the images will fall correctly on the retina. So also the corneal refractive surgery doing in the hypermetropia. This another condition is the astigmatism. We have discussed, told already. That is more than in case of more than one focal point. First of all, we have to make that focus to the retina, whether it is myopia or hypermetropia. First step is to make it into the retina. But in the retina, there are more focal points. Therefore, the next step we have to make that focal points come together, and we have to converge it to a single point. Therefore, 2 steps are needed in astigmatism. In simple astigmatism, the image is falling in the retina itself, but there are more than one focal point. Here, a cylindrical lens is enough. But in case of myopic astigmatism or hypermetropic astigmatism, we have to do 2 procedures. First procedure is to make it into the take that focal point to the retina, whether it is beyond or in front. Next stage, we have to make that single point. Then in normally astigmatism, maybe due to that, we have already told errors in the cornea, the normal curvature or normal smoothness of the cornea is lost. In that case, the light may not be focused into one point. Here, in late stage of in high astigmatism cases, if it is not corrected with cylindrical lenses, then a graft, or what's called a corneal graft, is necessary. Presbyopia. And coming to the management, diagnosis. So, first of all, when we are seeing seeing patients coming with refractive errors, we should take clearly the history, then the physical examination, then the chart examination, ophthalmoscopy, retinoscopy, and autorefractometry. The history taking is very, very important in refractive errors, because almost 60% of refractors are nowadays inherited. Also, physical examination that is the examination of cornea, examination of lens, examination of even eyelid is necessary. If there is any swelling in the eyelid, that may press the cornea, so that the normal shape of the cornea may be altered. That may cause refractive errors. Then the Snell chart. Then ophthalmoscopy. Ophthalmoscopy is nothing but we should examine the retinal part through the eye, through the front of the eye. That means normally we can't see the retina clearly, because in front of retina there is lens and then iris is there. The center, we can see the back of the eye only through the central aperture of eye, that is a pupil. When the pupil is dilated, only we can see the back of eye. When we light a torch to the eyeball, what happens? The pupil will constrict. We can't see the inner part. So therefore, we are using some mydriatic drug like tropin, etc. That will dilate the pupil so that we can see the inside aspect of the eyeball clearly. Then next is a retinoscopy. Retinoscopy is nothing but with the help of an instrument, that is retinoscope, we are calculating, or we are examining and calculating the power of the eye. Here also the pupil should be dilated. Then autorefractometry. Autorefractometry is nothing but the computerized vision test. It's very easy. The patient is seated in the correct position, in the chin right position in the autorefractometer. It will take automatically readings of refraction. Then what happens? A beam of light is going inside the eye, and it will be reflected back to the machine. That the degree and the direction of the bending of the light, or the refraction of the light, the machine can read. Therefore, it is taken in a printout. Very easy method nowadays. But we should not wholly depend on the autorefractometry. After taking autorefractometer, we should subjectively examine the patient, whether that the power that we got from the retina from the autorefractor is correct or not. We should examine with the trial set lenses. Then before going to the refractive errors, when the patient is coming with the dimness of vision, the most probably refractive errors complaints are complaints related to dimness of vision. Therefore, when they are coming with the dimness of vision, we should keep in mind some points, that is whether that dimness is sudden or gradual. If it is sudden, there are some more diagnoses. If it is a gradual onset, they are having some more diagnosis, other diagnoses are there. And also, if it is sudden itself, whether it is associated with pain or without pain, then also whether it is gradual itself, it is associated with the pain or without pain, should be clearly asked. As in case of gradual onset of dimness of vision, in case there is with pain, normally that is a chronic iridocyclitis. Chronic iridocyclitis means a chronic inflammation of iris along with the ciliary body. That is iridocyclitis, an inflammation of iris associated with the ciliary body. In this case, the iris and ciliary body are the part of vascular layer. That means the blood supply is there. It is most prone to infections, and there is severe pain is there. The next condition is glaucoma. In glaucoma itself, there is pain is there, but it's a gradual type of pain is seen in normal glaucoma. Also, in without pain condition, that is cataract. If a patient is coming with the dimness of vision, you just ask them or from what day the dimness starts. The patient can't tell in cataract because it's a gradual process. Then diabetic retinopathy, then retinitis pigmentosa. Diabetic retinopathy, as you know, it is a degenerative condition occurring in the retina. Also, retinitis pigmentosa is another condition. Here, what happens? Retinitis, that means inflammation of retina, causing degeneration of retina, mainly in the pigmented epithelial layer of retina. what happens? There will be residual pigments are there. Most probably it starts from the periphery of the eye and it will reach the center of the eye gradually. The main symptom of retinitis pigmentosa is you should ask them that the peripheral view, otherwise the field of vision is affected first. Then the later stage, the field of vision will increase and later it become tubular vision. It's another condition. Yet now there is no medicine for retinitis pigmentosa. The main management is it is an inherited disease. Mainly the consanguinity marriages should be promoted, and also if it happened, then you just advise them not to produce progenies because that gene will be inherited to generations. Then next coming is refractive. This coming the gradual onset without pain included they are the refractive errors. They are myopia, hypermetropia, and astigmatism. Then coming to the sudden onset of dimness of vision, should keep in mind with pain, that is acute congestive glaucoma. Glaucoma having so many classification, but in acute congestive glaucoma, that means there is closure of angle and pressure of the eyeball. Glaucoma, you know, that is increased eyeball pressure. Acute congestive means the pressure is increased suddenly, and what happens, there will be a high tension in the eyeball, then there will be dimness of vision associated with the severe pain. And next is the iridocyclitis itself, acute iridocyclitis. That means inflammation of iris and ciliary body. Then you should ask whether any fall of acid or alkali or any other substance in the eyeball or any fluids in the eyeball. In that case also there will be sudden onset of dimness of vision with pain. In all cases there will be pain is there. In also in without pain, in sudden onset of vision without pain conditions are the retinal detachment. It's an emergency condition. The patient may come with dimness of vision from the early morning or the yesterday. In that case, there will be no vision, no pain. In that case, the patient we should refer the patient, or at least we should do the fundoscopy. There will be a detachment. Detachment is it's a surgical management. We need a surgical management in it, because that the detached retina should be buckled or clipped back to the remaining retina. You know, the 10 layers of retina, there will be fluid. The layer will be detached from the remaining letter. The pigmented epithelial layer may be detached from the rest of layers, and there will be fluid in that space. So therefore we have to drain that fluid back and fix that retina to the previous position. That is a surgical procedure. Most probably it may come to our OP. We should refer immediately. That is dimness of vision without pain. That is sudden onset of dimness of vision without pain. This is an emergency condition. Also methylated spirit intake. Patient may have taken this type of spirit or alcohol, then come to OP. They will not tell to anybody in the home itself, and they will come to OP with dimness of vision. That is sudden onset. There will be no pain. Here what happens, the poisonous alcohol will affect primarily in the optic nerve, mainly the glial tissues of the optic nerve, and dimness start. There is no pain itself. Then in myopia, what happened? Difficult to see the blackboard. Then poor learning in classes. Difficult to see busboard from this. These are the complaints from myopic patients. And also mild headache, then severe watering, then tiredness of eye. These symptoms may increase on near work. Otherwise, these are called the astigmatic signs. Astigmatic signs are tiredness of eye with mild headache and increase, and the symptoms are increased on near work. Patient is coming with these complaints, we should go through the refractive tests. Then another symptom is the multiple chalazion. Multiple chalazion means eyelid cyst or chalazions. You know that these are the meibomian gland cysts. Meibomian glands are it supply the tear film. Tear film has 3 layers. Outermost is the lipid layer. That lipid is produced by these palpebral glands. severe straining, the overproduction. What happens? The straining may be due to the refractive errors. In that condition, what happens? There will be in this type of refractive error, there will be severe strain is there and severe watering is there. We can see overproduction of lipid layer. Lipid layer is a colloid or jelly-like. When it is produced in a large condition, what happens? The duct of it may be occluded and the gland may be swelled. If the patient is coming with multiple chalazion, we should first of all do then what refractive error tests. Then the study of some myopia. We have done taken for some patients in our daily OP. Then we had noticed some points that these are congenital. We have already told about the myopia. That's congenital simple myopia, then pathological myopia. Congenital myopia not associated with any degeneration changes in eye. The progress maximum up to 5 to 6 diopters. Simple myopia. Then we have taken a 50%, 50 patients from our OP below 25 ages. General and ophthalmic symptoms are noted and cataracts noted tridosha basis. A separate format was made for the purpose of clinical evaluation. We have taken the head associated symptoms of refractive errors such as headache, pain, eye strain, blurring, then blurring sensation of burning sensation of head, burning sensation of eye, photophobia, redness, heaviness of head, heaviness of eye, itching, watering, etc. We can see that the headache, pain, eye strain, etc. are seen in the patients with small age. That means age up from the headache, pain, and eye strain are most commonly seen in myopic patients. Then a chart with a reference to the condition of not condition but the symptoms of the patients, associated symptoms of the dimness of vision. And from that observation, we notice that in myopia, that is emerging from 0 to 5%, 4% patients are having myopia from 0 to 5%. Then from 6 to 10 years of age, 10% we got, 11 to 15, 10%, 16 to 20, 52%. That means 26 patients we got from 16 to 20 age limits. From 21 to 25, we got only 20. We had taken only 50, just randomly 50 patients. In itself, we got that inference that the more common myopia is seen in 16 to simple myopia is seen in 16 to 20 years of age. They are noticing it in 16 to 20 years of age. Then coming, more probably females are sexual distribution that we have seen in our study. Just OP level study. And according to Prakriti, Vata Kapha Prakriti patient, we got 26%, Kapha Pitta Prakriti 46%, Vata Pitta Prakriti, we got 20%, Pitta only, we got only 2%, Kapha only, we only got 2%. That means the patient having myopia is less having Pitta Prakriti. That means burning sensation and redness of eye. These are very, very diminished or not diminished. That we got only less patient with the Pitta Prakriti. Then coming to the simple myopia, about 22 patients we got with myopia, and 50% were myopic patients, and other myopic, the remaining were myopic astigmatism. That means with myopia there is astigmatism or astigmatism with myopia. Visual acuity. Then coming to symptoms of Vata and headache, pain, eye strain, blurring. In Vata symptoms, we got 64% were having headache. Then pain in 46%, eye strain in 42%, and blurring in 44% of patients. Here what happens, the headache is most common in myopia. And in pitta condition, burning sensation is only 8%, redness 4%, photophobia, blurring, burning of eye 6%. Most commonly, pitta conditions are more less in myopic patients. In Kapha condition, heaviness of eye 38%, heaviness of eye, heaviness of head, heaviness of eye in 14%, itching in 14%, and watering in 52%. The severe watering is seen in myopia, mainly due to the overstraining of the eye. And, distribution of total symptoms in Kapha and Vata predominant. Mainly Kapha and Vata is more predominant. Kapha and Vata lakshanas are seen in myopia. Also, Tridosha is 14% is seen, Vata 68%, and pure Vata in only 12%. Then we came to an inference that the pure Vata condition 12% we have getting in the OP. Vata Kapha is 56%, Kapha Vata in 12%, Tridosha in 14%. No associated symptoms in 3%. That means there is only blurring of vision. No associated symptoms are there. No specific symptoms of Vata, Kapha, Pitta are there. The majority of cases shown symptoms of Vata and Kapha. Patient with Kapha associated dosha prakriti greater predisposition are prone to greater predisposition towards myopia. Kapha and Vata condition is most prone to myopia. In minor group, there is no associated symptoms also. Pitta has no direct involvement in the development of myopia since none of patients exhibited pythia symptoms. But Tridosha conditions are seen only in case of Pitta predominant. Pittanubandha prakriti also. The myopia, it is commonly developed in active growing age up to develops in active growing age up to 20 years. Then these are the role of dosha. We have made some correlations. That's role of dosha in myopia. At the refractive index and the dosha. Refractive index cornea is 1.37 diopter. The more common, the most situated dosha predominance is Vata Kapha in cornea. Then acute humor, it is Kapha, lens Kapha, and vitreous also Kapha. In cornea only there is Vata and Kapha commonly seen. So actually, therefore, the refraction is the function of Vata through the medium of Kapha. Gurusnigdha guna of Kapha and Kuchala guna of Vata are involved in this. Then appreciation of these gunas leads to refractive errors. That's a combination of Vata, Kapha doshas clinically manifested in two ways. Kapha predominant Vata disorder, mild associated symptoms. Here in Vata predominant Kapha disorder, moderate to severe associated symptoms are seen. In Kapha predominant Vata disorder, mild associated symptoms, but Vata predominant Kapha disorder, more moderate to severe associated symptoms are seen. In both, the aniloma property of Vata is affected. Here in refraction, that means the normal refraction is altered. What happens? The aniloma property of Vata is affected in all cases. Therefore, the Kapha and Vata plays important role in refraction. Kapha Vatahara treatment. Our line of management is Kapha Vatahara treatment. That treatment will be effective in the management of myopia. And coming to the management, these are the Netra Kriyakramas and eye exercise are the management in our point of view, and also the giving suitable spectacles. Coming to Netra Kriyakrama, as you know, the Kriyakramas are Seka, Aschodana, Anjana, Pindi, Bidalaga, Tarpana, and Pudabhaga. Pindi and Bidalaga are explained by Bhakpada and Sarangada Samhita. Then coming to Tarpana and Pudabhaga, the main treatment we are doing for refractors are the Tarpana and Pudabhaga. And other things are the Purva Karmas of Tarpana and Pudabhaga. Then we should keep in mind that the Tarpana and Pudabhaga should be Vata Kapha decreasing type of medicine should be used. For Vata Kapha Hara medicine should be used in Tarpana and Pradavaga. Above all, we should examine the patient for the predominance of which dosha. In most cases, there is Vata Kapha predominance is seen. Then coming to the Purva Karma, as a routine procedure, we are doing the Purva Karmas like Nasya, Snehapana, Sedana, etc. Snehapana we can give as a Vicharana itself. We can give for 2 weeks to 20 grams twice daily, early morning and at bedtime. Then for that we are giving for 2 weeks. After 2 weeks we can take a Swedana by Ushma Sweda, or itself a hot water bath itself for especially children. Then next one day we can do Virejana, and then after that we can do Nasya, and then Anjana, then we can do Tarpana and Pradavaga. Before Tarpana, as the word itself, word denotes Tarpendi Tarpana, that means it's a Brahmana therapy. Also, before doing Tarpana, the dosha should be completely eliminated. Therefore, the Purva, especially the dosha, should be expelled from the body by Virejana, from the Sirus by Nasya, from Netra, from Anjana. Then we are doing the Tarpana. Tarpana we can do for 5 days as a common protocol. And also after Tarpana we should do Pradavaga, because after Tarpana the eye become less light heavy and it's sluggish, or it will have some tiredness. Therefore we should do Pradavaga. Then these are Aschodana, Sega, the other Netra Kriya Kramas. The other Netra Kriya Kramas may be explained in the coming classes. Then just noted here, in Aschodana we are doing in burning sensation, redness, watering, jaga, edema, then pain. Aschodana means the instilling or instilling of medicine in eyeball as a drop. It should be instilled from a height of 2 angulas, and it's matra or it's bindu pramana. Then segam is streamlined flow of medicated kashaya from a height of 4 angulas, and it should not be intermittent. It should have streamlined flow. Also in segam the eyes should be closed. We are doing in acute and chronic inflammatory conditions. Also in Shalana, in Anjana there is Shalana explained after Anjana. Shalana is same as that of Sega, but eye should be in opened position, because after Anjana there will be the remnants of the medicines there. We should wash it. That is Shalana. In Sega, the Acharya explained it as we should do in the closed eyes. This is Sega we are doing. The medicine should be instilled from a height of 4 angulas, and the flow should not be intermittent. It should be uniform, streamlined flow. This is Aschodana, medicine dropping in Bindu Pramana. Then the another procedure, Pindi that means a ball of kalka. Suitable kalka is rolled in a gauze piece and placed over eyelid. This is that we are doing in so many conditions. In refractory also, we are having some relevance. In case of keratoconus, like that, the cornea is pushed anteriorly, it will give some pressure effect itself. Here we are placing this for tolerance. If we are bandaging it in the night, it should be removed in the early morning. And if we are bandaging in the early morning, we should take it in the night. If there is severe pain or any irritation, the bandage should be removed. It's plenty. This is the condition keratoconus. What happens? The cornea, normally the cornea is circular in shape, but here what happens? It becomes cone shaped. That is, it's bulged anteriorly. When we are applying Pindi or pressure bandage, it will give some support to the cornea. But it should be examined previously, because in severe conditions of cornea, what happens when the corneal thickness is very much decreased and in the structure may be bulged out. In that condition, Pindi is not advised. We should examine whether the cornea is very healthy. Then only we should apply the Pindi. It is normal eye. There is a Bidalagam, another procedure, mainly used in Akshmagata or Vatmagata Rogas. It is same as that, the procedure is same as that of Mukhaleva. That means the medicine should be light, should be moist and should not allowed to dry. Also, it should not be applied in night time. Extra, mainly this procedure is done in Vatmagata Rogas. In refractive errors also it is having some relevance because in some, as I told previously, there may be multiple chalazion. In that case, the chalazion Bidalagam is very effective. And coming the Anjana, as you know, medicine is taken in the tip of the shalaga and is applied from Kaninaga to Abanga Sandhi. And after that, Shalana should be done. In considering the simple myopia, the Vatakopa Lakshana that we are seeing are axial lengthening of eyeball, then weakness of ciliary body. Here all what happens, Vatakopa, that means weakening of ciliary body, then nutritional deficiency, that means nutritional deficiency, debilitating diseases, endocrine disturbance influences the general health. Weakness and Dhadukshaya, that is nutritional deficiency, may occur in simple myopia. These all are Vatakopa Lakshanas. Then another, the Kapakopa Lakshanas we are noticing are the rays unable to pass through freely, hence focus in front of retina. That means the media through which light rays is going is altered, so that it can't correctly focus in the concerned part or in the retina. Here the eye is prominent and enlarged, then cornea become large, anterior chamber deep. These all are seen in myopia. Then pupils slightly large and sluggish to light. Here substitutes Kapavada Koba helps in reverting the course of disease. Mainly in the refractive errors, we are doing Kapavada mainly in myopia itself. Kapavada Hara drug should be used, or Kapavada Hara line of management should be used. In this case, we can do Nasya with Pradimarsha Nasya. It's enough in simple myopia with the Side Erandadi Nasya. Then Aschodana Tarpana with the Shadapodi. Shadapodi is enough for Vada Kopa. Then Netra Vyayama, that is eye exercise after Abhyanga or Sirius, and helps in strengthening the muscles and improves their tones. Then coming to these all are the management of simple myopia. Then coming to pathological myopia, we consider it as Tridosha disease. This disease is divided into 5 stages. In each stage, Tridosha involvement may vary. The simple myopia we can consider it as a Vada Kava predominant, but degenerative myopia, there is Tridosha involvement is there. The stage, they are having 5 stages. First stage is stage of prodromal symptoms. That means only dimness of vision is there. Here dosha dushti same in simple myopia. Findings are same in simple myopia, but the management is that of simple myopia. Same as that of simple myopia in the first stage of degenerative myopia. Then the next stage of the degeneration is the stage of progression. What happens? Vadakopa becomes more severe, and as increased Shita property of Kapha in the early stage further vitiates Vata also. Then Kapha Stairyata decreases. Then progression of myopia and weakness of muscles, especially extrinsic, and progression of myopia and weakening of muscles, extrinsic and intrinsic happen. What happens? The findings is optic disc. While looking through the by fundus, we can see the optic disc become pale and large. Myopic crescent can be seen. Myopic crescent means that is mainly due to the stretching of retina, there will be semicircular, that means crescent-shaped degenerative changes we can see, that mainly due to the stretching of retina. The treatment should be aimed in this situation. That means the stage of progression. The treatment should be aimed at restoring kapha, bringing about stamina of vata. Vata stamina should be done. Also, kapha should be bring backwards. This we can use medicines like Jeevaniya Grida for Pana, then Pradimarshanasya with Tiladaila, then Murdadaila with Shirabala is very effective. Then Tarpana we should done with Jeevaniya Grida. Jeevaniya Grida, that means Grida prepared by the Jeevaniya Gana. That means even the Kagoli, the Mudgabarni, same yoga. Then the third stage is stage of early degeneration. The first stage is after second stage, that is a stage of progression, degeneration starts. That is the stage of early degeneration. Due to the increase in Lekhu and Tishna guna of Vata, Tishna guna, Pitta becomes vitiated along with Vata. Already Vata predominance is there. And here the Lekhu and Tishna guna, due to the Lekhu and Tishna guna of Vata, the Pitta becomes vitiated along with Vata. With the involvement of Pitta, tissues in the eye, namely retina, choroid and vitreous become affected. Then the retinal epithelial changes become uncorrectable. Extensive pigmentary deposition causes pigmentary degeneration. Then degeneration of vitreous occurs. That means the liquefaction opacity. Normally vitreous is a colloid-like structure. That became liquefaction started and become opaque. Opaque means it's a clear fluid normally. When opacity occurs, there is dimness of vision started. The degenerative vascular changes of choroid causes choroidal halos and this is in macular region, resulting in Foster-Foch spots. The Foster-Foch spots are some pigmentary lesions due to the degeneration of macula and subretinal neovascularization. Normally, neovascularization means new vessel formation. Due to the degeneration or the lack of blood supply there, new vessels are formed, but the new vessels are not healthy. They will rupture and causes bleeding also, and causes some pigment lesions. It is called Foster-Foch spots. It is mainly seen in the first degenerative stage. This is a Foster-Foch spot seen through the ophthalmoscope. Degeneration of macula. Then coming treatment is directed towards Vata Pitta Shamana, because here Pitta involvement is there. Therefore, the line of treatment should be Vata Pitta Shamana. Chakshushi and Rasayana drug help in improving the health. This may be done with drugs like even Jeevaniya Grida itself. Jeevaniya Pradimarshanasya we can be done here. Then Shirabala as Murdadaila. Then Draksha Chandranadi as Tarpana, because these are Shida drugs involved in Draksha Chandranadi. It helps in the decreasing the vitiation of Pitta or for the stamina of Pitta. The next is the stage of degeneration. Actual stage started, the progression of vitiation of Vata and Pitta result in further degeneration of retina and choroid and vitreous. Findings: posterior staphyloma occurs. Posterior staphyloma means the bulging of eyeball due to the thinning of sclera. Sclera gives the structure to the eyeball. When what happens when sclera become thin, the posterior part of the eyeball become bulged. That is staphyloma.